Hello again. Today we will be discussing the musculoskeletal system and the medications that are used to treat some of the common musculoskeletal disorders. On this first slide, you will see the learning objectives and what you should understand after reviewing this slideshow. This presentation is relatively short. Please enjoy. Let's first talk about osteoporosis. This is a condition that mainly affects older women, and of course 80% of the patients diagnosed with osteoporosis are older women, especially those women that are postmenopausal. This disorder affects about 10 million Americans. Why is this so important for us to talk about? Well, this condition is responsible for as many as 1.5 million fractures per year. So the patients you're going to be caring for in the hospital may have osteoporosis, and usually the reason why they're in the hospital isn't for the osteoporosis, but it's due to them having an acute injury, and now they have a broken hip, they have a broken foot, they have a broken arm, and that's why we're now treating them. So what exactly happens with this condition? Well, bone reabsorption will outpace bone deposition, and then we end up with weaker bones. You can see in this picture here what a normal bone looks like, and then what osteoporosis looks like. So the bone is actually going to be reabsorbed where it's not staying within the bone itself, so now it's leaving the bone. And a lot of this has to do with calcium causing that bone to be reabsorbed. And I mean it's coming out of the bone, and now you can see we got these big holes within the bone, weakening that structure. Osteoporosis is the most common metabolic bone disease that we will treat. And what's happening? Well, the bone actually is now low in bone mass, low in density, and now we have increased bone fragility, which then, of course, can lead to just a minor acute or traumatic injury causing those bones to break. So now we're seeing fractures in those bones. Remember, within healthcare, we really are trying to prevent conditionings from occurring. So we really want to prevent osteoporosis. Since we know that it mainly affects postmenopausal women, we really want to educate them well to make sure they're doing their effort, putting forth their effort to prevent osteoporosis. So this means now they need to be taking in enough calcium in their diet. So think back to when we talked about nutrition in fundamentals. We want to make sure that they're following the dietary guidelines put forth by the Department of Health. We want to make sure they're eating enough calcium in their food. We also need them to be taking in and ingesting enough vitamin D in their diet. Another way to prevent osteoporosis is lifestyle. We want to make sure that they are maintaining a healthy, active lifestyle, especially as they're aging. We don't want them to become a couch potato and just be sitting around. We want to make sure that they are still active and getting up and ambulating and exercising as best as they can. How exactly do we get the diagnosis of osteoporosis? Well, they can do two different tests. They can do what's called a BMD test, and this will measure the bone mineral density. And another way is an X-ray, and this is the DEXA scan. It's a dual energy X-ray absorptiometry, which will actually show what the bones look like, and it will tell us whether or not they already have the weakened bones. We previously talked about how important calcium is within our diet. Well, why is it so important? Well, what does it do? Well, it will allow for the function of the skeletal system, the nervous system, the muscular system, and the cardiovascular system. It's very important for us to get enough calcium in our diet to make sure that all these systems are functioning appropriately. Our body will store calcium. Where exactly does it store the calcium? Well, more than 98% of it is stored in the bone. So this means that we want to make sure the calcium is staying in the bones and it's not being reabsorbed out of the bones, pulling that bony structure or bony fragments with it out back into the bloodstream and then being eliminated out of our body. We want to make sure that the calcium is staying in our body. How exactly is the calcium absorbed after we ingest it? Well, it's absorbed in the small intestines. If we have enough parathyroid hormone being released from the parathyroid, and if we have enough vitamin D in our diet, it will allow for an increase of absorption of the calcium in that small intestines. One thing that can decrease the absorption of the calcium is glucocorticoids. So anytime we have a patient that is on glucocorticoids, which is a steroid, it can put them at increased risk for osteoporosis. So we definitely want to make sure they are getting enough calcium in their diet so we are not causing the bone to be reabsorbed and pulled out of that bony structure. Calcium is excreted out of the kidneys, and calcitonin will augment calcium elimination. So we want to make sure that we don't have too much calcium going through our bloodstream, but we want to make sure there's enough so we are not pulling it out of the bone. If our patient is not getting enough calcium in their diet, a lot of times we have no idea because they don't have any signs or symptoms that they have hypocalcemia. The big thing is that if we don't have enough calcium, of course, then it can lead to or cause osteoporosis. So when we are treating, if our patient already does have osteoporosis and we need to treat the osteoporosis, what we need to do is make sure that we're decreasing the mobilization of the calcium from the bone. We want to make sure that the calcium, there's enough in the diet that the calcium is staying and it is being stored within the bone itself. Who's at risk for osteoporosis? Well, we already said that postmenopausal women, 80% of the patients diagnosed with osteoporosis, they are older women. So since we know this, we definitely need to put forth an effort and give good education to all postmenopausal women. Other people that are at risk are if somebody has high alcohol intake or caffeine consumption, it can interfere with the calcium absorption. Anorexia nervosis, if the patient is anorexic, they're not eating. Thus, this means they're not getting enough calcium, vitamin D in their diet. So we want to make sure that we are well aware of this and definitely assess them for osteoporosis. Tobacco use can put them at risk. Again, if they are using tobacco products, they probably are not getting the adequate calcium and vitamin D intake. Physical inactivity, if the patient's just sitting around doing nothing, it can lead to bone reabsorption. So it's pulling the bony structure out of the bones itself. So we want to make sure that we are assessing them also for osteoporosis. If a patient has testosterone deficiency, they can be at risk for osteoporosis. Lack of vitamin D or calcium in their diet, obviously, if they're not taking in enough, then they're going to have hypocalcemia. And then I already mentioned drugs such as the corticosteroids. Remember, this interferes with the absorption of calcium, so they would not be getting enough in their diet, thus leading to hypocalcemia. What exactly can we do to treat osteoporosis? Well, we do have some pharmacological treatments, 2 different types of drugs. The first agents, they are going to decrease reabsorption of those bony fragments, so they're going to keep the bone nice and thick and healthy. The drugs under that would be estrogen replacement therapy or hormone replacement therapy. That's what the HRT stands for. We have Evista, bisphosphonates, calcitonin, and denosumab. The other agent that we have is going to work a little bit differently. This drug is going to promote bone formation, so it's going to really help rebuild the bony structures. And this medication is Forteo. This is the only one that will promote that bone formation. Let's talk a little bit about some of these medications that will prevent reabsorption. Estrogen replacement therapy, it used to be the most common treatment, especially for those postmenopausal women. So what happens in menopause, you have to think about the pathophysiology behind that. In menopause, the patient, they no longer have functioning ovaries that will produce those hormones that are beneficial in maintaining the keeping that bone structurally together. So we used to give the estrogen replacement to all our postmenopausal patients, but what we have found through research is that we are benefiting in treating osteoporosis, but now we're also potentially causing problems. And remember, we always want to maintain safety with our patients and health promotion. And here we have a drug that can actually cause some problems. So the studies are showing an increased risk for uterine cancer, breast cancer, myocardial infarctions, and cerebrovascular accidents. So because of these increased risk factors, estrogen replacement therapy is no longer the drug of choice due to these risks. This slide just gives you a nice picture as far as estrogen replacement therapy. It shows you the good effects, and of course we see the positive as far as strengthening those bones. And of course, that's the problem that we have with osteoporosis. But then you can also see the side effects, those bad effects from using the estrogen replacement. Another drug that prevents reabsorption of the bones is called Evista. This drug works very similar to the hormone replacement therapy. What it will do is bind to the estrogen receptors, and then it's going to produce that estrogen-like effect on the bones. So it is going to help maintain the structure of those bones. The problem with this drug is it's not as effective as estrogen, but of course we don't have those secondary side effects that could potentially harm our patients. So these drugs are much safer. This drug is also less effective than bisphosphonates. So the patient, to treat osteoporosis, we're probably going to use the bisphosphonates instead. The good thing about Evista is that it does decrease that bone reabsorption, so it will increase that bone density. And we also see a positive effect as far as preventing uterine and breast cancer, because it is going to block the estrogen receptors in those locations. So that is a very positive effect. The most common drug class that we are seeing used in the treatment of osteoporosis is the bisphosphonates. And these type of medications, they're not only going to prevent osteoporosis, but they're also going to treat the osteoporosis. It is structurally related to pyrophosphonates, and so it's naturally going to inhibit bone reabsorption. So that's positive for our osteoporosis. We want to make sure that bone is staying nice and thick and healthy. You can see the examples I have listed there. We have Boniva, Fosamax, Actone, and Reclass. Notice the common theme in the drug names. So those generic names, we have dronate at the end of all of those. So all of those are our bisphosphonates. Some common things to remember with our bisphosphonates is that the medications are going to be poorly absorbed from the stomach. Therefore, we need to make sure our patients are taking these medications on an empty stomach. No food. They should not be eating at all when they are taking this medication. So think back to what we have learned in past lectures. We need to make sure as much of this drug is being absorbed as possible, because the bioavailability of this drug, or these type of drugs, very low, only 0.7% when given PO. If the patient would take these medications with any food at all, notice 0% bioavailability. So waste of time, waste of taking the medication. So we need to educate these patients very well. Other thing that can affect the medication is coffee and orange juice. That will also decrease the absorption. So you need to make sure these patients are not drinking coffee or orange juice. And that's common for them to take their medications using those types of drinks. A lot of older patients, they do drink coffee. They drink coffee a lot. A lot of them drink it with every meal. So we need to educate. No coffee. They need to make sure they're just taking these medications with water. A lot of times these patients are going to take these medications at breakfast time, and orange juice, that's a common drink that patients will drink with their breakfast. So no coffee, no orange juice when taking these medications. When taking bisphosphonates, 50% of the drug that is absorbed rapidly will go through the body, go directly to that bone. Once it's in the bone, what they have found is that the drug will remain in that bone for decades. So it's going to help strengthen and keep those bones intact. Very good thing for osteoporosis. Of course, this positive drug that we have, there's an adverse effect, and it is pretty major adverse effects. We can see esophagitis, and we can also see esophageal ulcers. Why would this happen? Well, of course, the medication is being PO, and what can happen is it could end up not being absorbed very well, and then it remains on that esophageal mucosa. It's not passing through the esophagus well, so it can lead to complications. That's why they need to drink water when they are taking this medication, making sure it's getting out of the esophagus, getting into that stomach so it can be absorbed. So here are things that we really should recommend to our patients. Make sure that they are taking this medication in the morning. And of course, they should drink water when they are taking this medication. And they need to wait at least 30 minutes before they have their coffee, before they have their orange juice, before they eat any food. I already said, drink lots of water when they're taking these drugs. And then they should remain upright for at least 30 minutes. Why? Well, this will allow gravity to work, and it will allow the drug to get out of the esophagus and get into the stomach where it needs to go. So we're not having that adverse side effect of esophagitis. We have seen in recent studies that there are new recommendations that we can just do once a week dosing with medications. And then the Boniva, that can be administered once a month. So much better than having to take a medication every day or several times a day. So, we're not having to administer this very often. Once it's absorbed, it goes rapidly to the bones. It's staying there for a lengthy amount of time, so it can be effective for many years. Other treatment for osteoporosis is calcitonin, and examples of this is miacalcin or Forticol. Hormones are secreted from the thyroid gland, and what's happening is these hormones will lower the serum calcium level, so taking it out of the blood and then moving the calcium to the bone. So good medication, it's allowing more calcium to go to the bone to prevent reabsorption of that bone back and to be eliminated. We're keeping that nice thick bone. Problem is, we're not seeing this drug to be as effective as other agents. And then notice the way it's administered. One way is sub-Q, and of course that's going to be very difficult to administer to our patients. The better administration route would be the nasal spray. Remember, ease of administration. A patient's more likely going to take a nasal spray. We don't want to be giving injections at home if we can prevent that. We do have some other choices as far as treatment for osteoporosis. We have Prolia, or Exgeva is, I think, how you pronounce that. This medication was approved in 2010. Problem is, we're not seeing it being used very often. Why? Because of the way it has to be administered is sub-Q. And remember, it's not easy to give a drug to a patient if it's going to be in injection form. A good thing, though, would be that it only needs to be administered once a month. It does work pretty good. It's helping the body to decrease formation and function of the osteoclast. So then what's happening, it's decreasing bone reabsorption, so it's keeping that bone nice and thick and dense and giving good strength to that bone. Let's talk about another musculoskeletal condition, rheumatoid arthritis. This is a progressive inflammatory disorder, and it is considered an autoimmune disorder. What exactly is happening in rheumatoid arthritis? Well, we're seeing inflammation in the synovium, and the synovium is a membrane that encloses the joint capsule. So where exactly are we seeing the signs and symptoms? Well, it's right there at all those different joints. So lots of joints in the fingers, we have joints in the hip, in the wrists also, in the elbows, in the knees. The most common place you're going to see complications from rheumatoid arthritis is in the hands. I mean, everybody looks at other people's hands. It's a very noticeable thing. And over time, as the condition worsens, we do see deformation in the hands. And once the disease progresses to a point, we can't get that mobilization back in those joints. The patients, the symptoms that they experience is going to be symmetrical joint stiffness and pain. So it's not just one-sided. It's going to be all the joints are affected. In the mornings is going to be the worst time for their patients. This is when the symptoms are most intense. They've lied in bed all night, they were immobile, and now we need to get those joints moving again. So first thing in the morning, getting up, getting moving, it's going to take a lot of time, a lot of effort to get those joints working. So there is some systemic manifestations with this condition. They could experience fever, weakness, weight loss. They could have thinning of the skin. So we do need to assess our patient for these different things. With rheumatoid arthritis, we do have some goals of treatment. The biggest thing that they complain about is painful and stiff joints. So we want to help relieve the pain. Of course, what's the pain coming from? It's going to be due to inflammation. And of course, they're going to be so stiff, and it's going to be very difficult to move those joints. We want to make sure those joints maintain their function. So think back to fundamentals. We want these patients to go through range of motion. That means with all those joints. We want them to be able to do active range of motion as long as they can. As the condition worsens, we may have to do passive range of motion on those joints to help maintain that function. We also want to minimize systemic involvement, so make sure that we are taking care of the fever, taking care of that weakness. And then, of course, we want to delay disease progression as long as possible. Like I said, we want to make sure that they are staying active and the condition is not worsening. Non-pharmacological treatments that we can do for these patients with rheumatoid arthritis. We can send them to physical therapy, and usually in physical therapy they're going to talk to them about applying heat to those joints. And one way to reach a lot of joints at once is by taking a warm bath. That really can promote blood flow to those joints. Another thing we want to make sure they're doing is maintaining the range of motion in those joints. So we do want them to be active. We want them to be able to perform their activities of daily living. So exercise is going to be recommended, but these patients are going to be very weak. It's going to be very difficult to exercise. So we really need to balance between the rest and the exercise. Another thing that we want to make sure they're doing is not exercising too much. If they're exercising too much, now we could worsen their condition and we could cause inflammation to those joints. A very good exercise that it takes the pressure off the joints. Water aerobics is very wonderful. Swimming, getting into that pool, the swimming pool, getting into that water, it's very helpful for this. Problem is, depending on their location, wherever they live, they may not have access to a swimming pool. So physical therapy, if we can get them into one that has the water exercises, would be very beneficial to them. Our patients may need to have surgery. We do have joint replacement surgeries, so think about hip replacements, knee replacements. We typically don't see replacements in the joints in the finger. It's not beneficial to take care of those joints. So with the hands, we want to make sure that they are still using their hands. We do not want permanent depletion of those joints to occur. Main goal with rheumatoid arthritis when it comes to pharmacotherapy is to make sure we're reducing the pain with our patients and reducing the inflammation. So we do have different classes of anti-arthritic drugs that we will use. The main thing we are using is NSAIDs, so those non-steroidal anti-inflammatory drugs. We also will use glucocorticoids. Typically, though, this is just going to be short-term therapy. And then disease-modifying anti-rheumatic drugs. That's going to be the DMARD class of drugs. The DMARDs, typically, that's going to be our first line of treatment. That used to be our second line of treatment, but what they're finding is the DMARDs will help with preventing the disease progression. So we really want to start doing that as early as possible. NSAIDs work very well, especially for relieving short-term those symptoms that they're having, so that pain and that pressure on those joints. With the NSAIDs, they are not going to help prevent the joint damage. They're also not going to slow down the disease progression. NSAIDs are definitely safer than the DMARDs or glucocorticoids. We do not see a lot of side effects as compared to the DMARDs or glucocorticoids. The glucocorticoids, they're also going to provide rapid relief of symptoms, can potentially slow that disease progression, but we cannot use glucocorticoids long term. There are serious side effects, and we're going to talk more about glucocorticoids later on in the semester. What do the DMARDs do? Well, they're going to help reduce joint destruction. The main thing they're going to do is they're going to help stop and prevent that disease progression. With DMARDs, it does take a little bit of time for them to start working, so we may not see any benefits several weeks to months. So we want to make sure we educate the patient. They need to continue taking the drugs as prescribed. And we need to tell them it's going to take a while until you see positive effects from these medications. These type of medications, DMARDs, they do have narrow therapeutic range, so the potential for toxicity is definitely there. We need to be doing our blood test and monitoring for toxicity. We need to closely monitor this. We are definitely more aggressive when treating rheumatoid arthritis. We used to not be as aggressive, and we used to just start with an NSAID and then eventually progress to the DMARD when needed. And then, of course, just use glucocorticoids for short-term therapy. New treatment plan, though, we're definitely more aggressive. We're a little bit more gung-ho in trying to prevent the progression of rheumatoid arthritis. So we're definitely going to start the DMARD as early as possible. We really want to get that started within 3 months of the diagnosis. It's going to help delay that joint degeneration. Remember, though, it does take weeks to months to start seeing the effects of the DMARDs. So in the meantime, we can use the NSAIDs to help relieve the symptoms of pain and inflammation of the joints until the DMARD kicks in and it starts working. Different DMARD agents that are out there to treat rheumatoid arthritis: methotrexate, we have zolpidem, Plaquenil, Enbrel, and Remicade. The most common one that they seem to be using lately is methotrexate. Why methotrexate? Well, it does act a little bit faster than the other DMARDs. Remember, it can take weeks to months for these DMARDs to start working. Methotrexate, we're seeing it start to work. We're seeing those therapeutic effects typically 3 to 6 weeks after we start using it. This is considered the first choice treatment. Methotrexate is actually considered a chemotherapy drug, and what it will do, it will kill fast-growing cells. When we are using it for rheumatoid arthritis, we're just using a small dose. So when we're using this smaller dose, it's going to work as an anti-inflammatory agent. One thing, though, that methotrexate can do is it can cause immunosuppression, so it can put the patient more at risk for other illnesses, infections. So we want to make sure that they are well aware of this, and they should stay away from people that are contagious. When we're administering the methotrexate, it's only going to be administered once a week. It can be administered orally or by injection. We need to make sure we're monitoring them closely. It can potentially cause harm to the liver and kidneys, so we need to monitor liver and kidney function. Another thing that we need to also monitor CBC. Why? Because it can cause aplastic anemia. It can also cause leukopenia. So we need to make sure that we are checking to make sure the blood counts are okay. The Enbrel and Remicade, these medications, we are seeing good effects where it is neutralizing the tumor necrosis factor, which will contribute to the pathology of rheumatoid arthritis. These medications, Enbrel is given sub-Q, Remicade is given via IV. The problem with these drugs, very expensive. You can see $14,000 to $35,000 per year. And we're not using these medications as much because the insurance companies are not wanting to cover the costs. Why? Because it's cheaper to use a different DMARD, such as methotrexate. The Enbrel and Remicade, if we have a patient that does a moderate to severe rheumatoid arthritis, we can give these medications along with the methotrexate. Problem is since we're already giving methotrexate, which is an immunosuppressor, and then either of these drugs can cause immunosuppression also. So we need to watch our patients closely for signs and symptoms of infection. Another condition that can affect the musculoskeletal system is gout. This is an inflammatory condition, and what it will do, it will attack the joints, tendons, and other tissues. The most common site that we see the gouty arthritis, which is another term that they use for gout, most common site is the joint of the big toe. What happens in gout is that uric acid, it's a uric acid metabolism disorder, and what happens is an increase of uric acid builds up within the bloodstream, and then the uric acid accumulates, it gets stuck, and a lot of times it gets stuck right there at the big toe, and now we have a painful joint, and a lot of times the patient is complaining of this pain to their elbow, their hands, base of their large toe. And we can also see bumps appearing, and of course that's in that subcutaneous tissue. And why? It's because those uric acid crystals are accumulating there. And you can see that in that picture that's listed there. Like I already mentioned, gout characterized by hyperuricemia. So if we would check their blood levels, we're going to see an accumulation or a high level of uric acid. Why is this occurring? Well, their body's either producing too much uric acid or the kidneys are not excreting enough uric acid out of the system. A lot of times our patients, they end up having acute attacks. And why is this? Well, it's precipitated by that crystallization in the synovial space. So a lot of times it's that joint of that big toe where they're really having a lot of complications. What can we do for these patients? Well, the goal of the treatment is to help relieve the symptoms. We will give medications short term, and we're going to help relieve the pain and the inflammations. The main thing we want to do when we're treating the gout is to make sure we're treating the cause. Remember, the cause is that overaccumulation of that uric acid. So what we really want to do is lower the blood levels of uric acid. This is going to help prevent further gout attacks. If we don't have those high uric acid levels, we're not going to have accumulation of that uric acid, which then will cause the pain to the joints. Again, we can use NSAIDs to help treat our gout patients, so those non-steroid anti-inflammatory drugs. We will use these medications as our first choice of treatment, and really what they're helping to do is to prevent the inflammation at those joint sites. Indocin and naproxen are the common ones that we're going to use. We can also use glucocorticoids. Remember, this is going to be steroid treatment. We can use this when the NSAIDs aren't tolerated. And of course, prednisone would be the drug of choice for the glucocorticoid. But remember, that has to be short-term use. There's too many side effects if we would put a patient on glucocorticoids for long-term. Another medication is colchicine, and this is an anti-inflammatory agent, and it's specifically for gout. So we do see positive effects from this. The drugs that we need to use to decrease the uric acid levels, so they're really treating the hyperuricemia. We have allopurinol, we have febuxostat, we have probenecid, and pegloticase. The most common one that we will use, and the one that we're seeing the most with our patients, is allopurinol. What exactly does allopurinol do? Well, remember, what's happening in gout? Well, we have that increase in uric acid blood levels. So allopurinol is going to help inhibit the uric acid. It is going to be our drug of choice. And what it will do is inhibit the final steps of uric acid biosynthesis. So essentially what it's doing is lowering serum uric acid levels. That's great, because then we won't have the accumulation in the synovial of those joints. So we can use allopurinol as a prophylactic treatment. So long-term use, they're going to continuously take this medication, and it's going to help prevent other gouty attacks. We definitely want to encourage our patients to increase their fluid intake when they are taking allopurinol.